thinking about chemotherapy in the day, and I practiced back in 1985, and I walked on to a ward at the National Cancer Institute at NIH here in Bethesda, and one side of the rooms were filled with these young men with this pneumocystis pneumonia we knew nothing about, and they were basically dying from something we now call AIDS. The other side would be people fighting for their life on phase 1 and 2 clinical studies, mainly chemotherapy, fighting for their life for different cancers. And it was a world awakening to a new nurse, for all you nursing students. It was a different place. Working at NIH was an amazing time and place. I didn't think about cancer prevention and screening. You know, we were struggling with other things. But through the years, I learned there was a way that we could potentially prevent and screen these patients. And through that, as a nurse, I became a nurse practitioner to be an advocate for my patients and look at all the holistic way we could take care of patients, not just wait till they have stage 4 metastatic cancer. I worked from NIH to Sloan Kettering. And from Sloan Kettering, I received a call from a physician from NIH saying, we're going to UVA and we're going to start a big cancer program. So I tagged along and came into Charlottesville and was in the 90s where we began doing these tests called BRCA1 and 2, and I helped run a cancer genetic program. Back then, in the mid-90s, when this test became available, no one really knew about it. And people that didn't want their insurance to know about it. They didn't want to stir anything up, so they would pay thousands of dollars to get this test. Well, obviously you know about this test now because we have a celebrity, Angelina Jolie, who has skyrocketed up all the testing for BRCA1 and 2, which is amazing. So we have this kind of education. But now we have over 40 cancer genetic tests, because 5 to 10% of many cancers are caused by a gene that we inherit from mom or dad. This is the new way to prevent and screen people. Yes, it's a small number, but we're doing it now in breast. We're doing it in colon cancer, something called Lynch syndrome. And what we need to advocate, not just for people in oncology, but for healthcare providers, nurse practitioners in rural settings, in family practices, to take something very simple, take 2 seconds to ask a very detailed family history. You know, just don't say, what did your mom die from? But yes, did she die from breast cancer? Well, what age did she die? Red flags for hereditary mutation are young age of onset. And people think, oh, just breast cancer. But look at the other cancers. People don't realize that BRCA2 is the breast cancer gene. Your lifetime risk of getting breast cancer with that gene is close to 80%. But did you also know that it's almost a 22% of ovarian cancer risk? And pancreatic cancer is 6 to 8%. 3 times increased risk of melanoma with the disease, as well as prostate cancer. So you have to do a very detailed family history, asking grandparents, nieces, cousins, and look to see if you can find some hint of a hereditary mutation. So this is slow in coming, and something I'll talk about, that tools that we need to help primary care physicians, nurse practitioners, nurses identify these patients. I was doing medical oncology. I've been in private practice for over 30 years, and emotionally it takes a toll on your heart and soul because you get very close to these families, these patients. And 3.5 years ago, I had an opportunity from a couple pancreatic surgeons at the University of Virginia, who are cancer centers now named after Emily Kurek, who died of pancreatic cancer. She was a very amazing woman. I think she would have been the governor of the state of Virginia. She worked hard and effortlessly for our community and education. I loved being in her presence. She was an amazing woman. And she died from that disease, and the cancer center bears her name. And these pancreatic cancer surgeons lured me away from medical oncology practice to start a high-risk pancreatic cancer screening clinic. We've heard about mammograms, we've heard about colonoscopies, pap smears, but no one, when you look at the guidelines, especially from American Cancer Society, there are no guidelines for pancreatic cancer screening. Some of my colleagues actually laughed at me a little bit because they were like, there is no screening, there is no prevention for this disease. How can you take this job? Well, it was a grant-funded position. It's nurse practitioner run. I run it by myself. The surgeon said, here it is, go and run with it, start it. So I'm 3.5 years in. And pancreatic cancer is rare. You have to remember, the general population is 1.5 people out of 100. So it's very small. But there are families out there, and I'll bring up one patient of mine, my first patient that kind of signed up for my screening program. He had 14 family members die of pancreatic cancer. He was a physician from North Carolina. And he came to see me. He had one aunt. We said, we got to test someone that's alive. He had an aunt passing from the disease in a nursing home. And I said, let's test her. And he's like, oh no, do this test. Medicare would only pay for BRCA1 and 2. They wouldn't test. There's 13 genes now that we know are attributed to pancreatic cancer. She was negative. She passed. He came to see me, and he said, this is 4 years ago, he's like, I want to do the whole panel, this whole 13-gene panel, which costs $7,000. Insurance wasn't covering it then. They didn't think it was medically necessary. He paid out of pocket. He had the funds, which was nice. And I told him, the panel came back completely negative, but it didn't really help us. We don't know, is there a gene we haven't discovered? Was he a true negative? Did he not have the gene that was inherited? But I said it was the best Christmas present he could give his children. We'll go from there. And every day we're learning more genetic mutations that are being seen and developed not only from the angle of treatment of these diseases, because we know BRCA1 and 2 patients actually do better clinically, interesting enough, and we're gearing treatments based on these genetic abnormalities to treat them. One is with PARP inhibitors for BRCA1 and 2. So it's an amazing science that is going on, and we need to support the science. The clinic that I started, I've seen probably over 600 patients in the 3 years. I found one pancreatic cancer to date. I model my program after, I have to applaud these other centers. Hopkins is one of the first that has a high-risk pancreatic cancer screening program. And they have a consensus statement. Who should we screen? We don't go and screen everyone, but who should we screen? So we do follow a consensus guidelines that was published by Mimi Canto. And recently there's a great publication, and there's resources and references, I think, on the web in 2016. But we follow strict guidelines, and we follow Hopkins, Sloan Kettering, IU, Dana-Farber. Some of these have IRIS programs. And they are doing very interesting research where people come in with strong family histories. And when I say strong, to be a candidate for my program, and I get draws from North Carolina, Pennsylvania, Florida. I've had people come from other family members all over. You have to have at least 2 first-degree relatives carries the highest risk, so a mother and a brother. Does that make sense? That would carry a 5 times increased risk. We don't screen everyone. So if you have one family member, we don't really screen that person. Or you have one of these 13 genes that we can test for. So when they come, I do it's intensive on the phone, and I only run this clinic 1 day a week. I do other clinics too. I work with melanoma, I do a bunch of other stuff, but I have to screen every person to see if they're a candidate. And when they come, I call the trifecta visit, I look at their family history, I get them to see the cancer genetic counselor, if they have not been genetically tested, if they meet criteria. I see them, and I discuss the benefits and risk of screening for pancreatic cancer. So right now the consensus is starting at age 40, or 10 years before someone was diagnosed with pancreatic cancer. We talk about the risk and benefit of either an endoscopic ultrasound or an MRI of the abdomen. Those are the best ways to look at the pancreas. There's no magical blood test we can do to screen for pancreatic cancer. So the next fight is the insurance. Will they cover screening these people that are very scared of developing pancreatic cancer? I have today gotten most of the endoscopic ultrasounds paid for. Insurances are now starting to pay for some of the MRI. MRI is about $3,000. Endoscopic ultrasound does require anesthesia, so there's some risk and benefit. And a lot of people come and they say, oh, my risk is, I can calculate the risk. A PhD at Hopkins developed a model called PancPro. And you can put in, like the Gale model for breast cancer, and you can actually kind of predict what someone's lifetime risk is of developing it. So when these patients come, we do have a really detailed discussion about that. And they come in and they're frightened. They see what their risk is. It's not really high. Is it high? The highest risk is someone with hereditary pancreatitis gene. It's STK11. That risk is about 30%. Like we talked about BRCA2, more commonly 6 to 8% lifetime risk, which seems small, but these people are scared because they do have family members that die of the disease. We decide screening. We screen them annually. I'm keeping a database of these patients I see. But the best part of this clinic is education. It is the only clinic, and I've talked at the American Institute on Cancer Research. I recommend you get that on your favorites, aicr.org. It's amazing research they do. It's all evidence-based on diet and exercise. It's the only clinic in the cancer center that our average BMI, when I looked at it, was 30, close to 30. So that's obese. So that's based on your weight and height. So it's the only clinic in UVA, in many places I'm learning from the AICR, where every patient, I work with a nutritionist. So they're like, oh, it's her again. I don't want her to come in and talk about what I'm going to eat. But they're frightened of cancer, but they weigh 250 pounds, and they don't exercise. So it's we do a lot of diet consultation. We are doing follow-up with our dietitian interns to help motivate and inspire these people to lose weight and start exercising, and they get it. People don't even understand that Medicare has a great Silver Sneakers program, giving them resources of where they can exercise. The other thing we add is I have these great athletes from UVA who are also exercise physiology students, and they're really fun, and they come and work. And my dream would be to have a mini gym on the 4th floor of our cancer center. Like, okay, you've met with me, you're going to decide if you're going to screen, you met with the nutritionist, now you're going to go work out, And they're going to be, and we're going to train you, and they're like, oh. But that would be my ultimate. So it's, what we need to do is, it's a small clinic. It's a low population risk of people, but it's the 4th leading cause of death. By 2030, it is going to be the 2nd leading cause of death. We know there's environmental aspects. We know diabetes is the big risk factors, obesity. 365 cancers out of the estimated 4,600 cancers diagnosed a day are caused by obesity. And smoking is another big, big risk factor that increases one's risk highly of pancreatic cancer. So smoking cessation is also a part of that, of our program, and referring them for that. So really, in the end, we have to get better at covering these, helping our healthcare professionals identify these people with cool tools, computer links that flag this person has a family history that may be hereditary. There's things in the making, but it's not come to fruition yet. We also have to support our cancer genetic counselors. Medicare does not cover their services. So unfortunately, grandparents come in and they're concerned, but they don't want to pay out to meet with a cancer genetic counselor. So trying to get coverage for service for them is imperative as well. And I want to thank you. I left brochures out there with my card if you have any questions. And thanks for having me.
Kathleen, you're amazing.